Thank you, Jack. You came back from lunch. Okay, this is really, I was not expecting this. We had two fantastic talks by Dr. Kola, going deep into, I don't know if you realize this is, dissecting every cell in erythropoiesis, doing single cell analysis and coming with pathway that we can target. So congratulations, Dr. Kola. And then, Matteo, I've seen these papers, but now I understand them actually. And I think this is going to be a key question. So we go from what I think is very important translational sign now to kind of mundane clinical treatment of high-risk MDS. Okay, so I cannot see the clock from here, but I'll try to do my best to stay on this 10-15 minutes. So I think what we are learning as we mature our approaches to these patients is that we have 4 potential characteristics that really determine how we treat these patients. Of course, age, I think is becoming very clear whether the patient is a candidate for a stem cell transplant, and more fundamental, as we heard from Dr. De La Porta, genomic and cytogenetic profile, together with this issue of comorbidity. So these are the things that I look when I see a patient in my clinic with this disease. Today, we're going to look at those patients with high-risk disease on the right of the photo. And I know that in Europe, I don't know actually in Italy 100%, but in some European countries, they never use these hypomethylating agents for low-risk disease. This is what you do for high-risk disease. But it's very fundamental to differentiate those patients that are receiving this agent up front versus those with this so-called hypomethylating agent failure disease. This is really problematic disorder with very different biology, very different prognosis. So we'll try to cover a little bit of that. And then I think probably I showed a similar algorithm the last time I was here in person in Rome, and I forgot actually to thank Claudio and the organizers for having us here, and particularly to be here in Roma in person. But if I had this slide, probably the biggest change is actually in little red thing, that is the incorporation now of this IPSSM classification that I'll briefly mention, that I think was just published a few weeks ago, and I think is one of the most important things that has happened in our field. Now, this is our standard of care, has been here in this disease for this subgroup of patients for the last, 15 years or so, and still is the standard of care. This is very sad. Actually, I think they need to fire me from MD Anderson, because the question is, why are we not doing better 20 years later? I mean, why we cannot really do better than this, okay? Now, we're making some small progress. Now, you may say this is progress or maybe not, but we are very excited about this. So this is the approval a couple of years ago in the United States of an oral form of a hypomethylating agent. This is the combination of oral decitabine with cedazuridine. Now, this is interesting because this is not actually the drug that you think, for instance, the oral azacitidine, the CC486, that has a very low PK profile. So this combination basically gives you the same pharmacological profile as the IV or subcutaneous decitabine. So this was based on this clinical trial known as the Ascertain trial. This paper actually is being reviewed as we speak, although has been published a couple of times. And actually it's interesting phase 3 randomized trial. Here what we did was basically to compare the pharmacological and pharmacodynamic profile of the oral decitabine versus the IV decitabine, and we randomized the 2 different sequences. On top, patients started oral, and then the second month they did the subcutaneous, and in the other arm, the reverse. And this basically allowed for intra-patient comparison at very high level of these 2 drugs. And the FDA told us, look, if you show that they are similar, we'll give you approval of this compound. And indeed, the approval of that drug is based on that red box here, 99% identical. So basically, this oral compound is identical to the IV decitabine. Is this any better or any worse than azacitidine or the regular? We don't know. But the clinical activity is actually quite interesting. So this was published and presented at ASH last year with a complete remission rate with this single agent oral decitabine of around 22%. That compares very well with what we expect with subcutaneous or intravenous azacitidine. Now, as we move, I think that we may not be making a lot of really incredible progress with new therapeutics, but I think we're getting smarter about how we see our patients. And Dr. De La Porta already told us how we do that. And I think it all comes through the genomic analysis of these patients. So this is fundamental paper by Dr. Papamanuel. I think there were 4 or 5 papers around 10 years ago looking at this molecular cartography of patients with myelodysplastic syndrome. So we are not going to go through this, but there is a detail on this graph that I think is very important. That is, when this genomic data came out, we thought that somehow cytogenetics were going to disappear. They were not going to have a role. They were not important, that everything was about mutations. But actually, if you look at there, you see in red, says del5q, complex, etc. for some reason, these big structural cytogenetic changes, they retain prognostic and biological value. So basically, cytogenetic alteration is not the same as molecular alteration. This is very, very important. Now, what has happened, and this took us like 10 years to put together, is this beautiful classification. So I'm sure all of you are using this. I use this in my clinic now. It's actually very democratic and free. You go to the internet, put IPSSM, it comes out, and it takes you 2 seconds actually to calculate this. Actually, someone in our group has kind of downloaded the algorithm, and now we're looking at hundreds and hundreds of patients patients with MDS in a few minutes. This is really important. So basically, what Elsa Bernard and this big consortium led by Dr. Papa Manuel put together a very large cohort of patients with MDS all over the world, different countries, etc. And they look at them from a typical IPSSR-like profile and the genomic analysis of 17 genes. And then what happens now is that you can differentiate these patients into these 6 subsets, from the very low to the very high. This is really phenomenal data. Now, our group had published, Dr. Montalban, a few years ago, kind of similar data just with 800 patients. Now you have here several thousand patients that in a second you can basically predict what's going to be the prognosis based on their mutational profile. Now, if you use this, what you're going to learn is that actually you tend to upstage the prognosis of these patients. So people that we used to call low risk, now they're going to be intermediate. Some of these intermediate actually are going to be high risk disease just because of the accumulation of mutations. And there's a new subset of patients that I see in my clinic quite frequently that they may not have excess blast, they may not have actually significant cytopenia, and they have 6, 7 mutations. And the prognosis is really horrible. And if you remember, we used to call them low risk, poor risk MDS by this old MD Anderson classification at the time when we didn't have cytogenetic or molecular significant data. So this is going to transform actually how we see our patients. And that's why I'm so concerned about this ICC and all these stories, because now we have beautiful model and we're going to get all this confused with this kind of dichotomy of more or less than 10% blast, these kind of things that I think are going to be complicated. Now, one thing that we're proud also from our group is that even if probably in Italy this is not an issue, I can tell you that around the world, obtaining cytogenetics is actually quite difficult. In many places, they just don't have access to this. They can do NGS, but they cannot really do routine cytogenetics. So our group, a couple of months ago, published in leukemia the first assay using this optical genomic mapping, this BioNano device that will allow actually for kind of like automation of this cytogenetic analysis. And data that was published in this paper shows actually that we can basically obliterate the group of patients with inadequate metaphases, those patients that you cannot read because you don't have enough cells. So I think this may be kind of expensive, but maybe actually very democratic in the sense that you don't need now a technician to really do those metaphases spread. So this is going to be important data. I know in Spain, actually, they're starting to put this kind of device into CLIA environment in the clinics, at least in Valencia. Now, let's look back at this issue of the molecular data. So I think Dr. Fallini was here in the morning, and I asked this question to him like around 3 or 4 years ago. He told me, no, you're wrong. These are AMLs. But trust me, they were actually MDSs. And the point that I'm trying to make here is that there is 1% of these patients with this so-called NPM1 mutated MDS. And why is this important is because if you don't do your genomic in these patients, you will miss it, because these patients are true morphological MDS. Now, you do your NGS test, they are NPM1, now we're going to call them AML. But the reality is that I'll tell you that in the community, we will miss a lot of these cases. Now, what we published in this example here is that, unfortunately, this happens in 1-2% of the patients. But if you identify them, actually, you cure them. So if you didn't have this data, you will give them an HMA, and you see in blue what the survival is. If you find them, in red, you give them induction therapy like an AML program, and they actually need the stem cell transplantation, and then you have close to 100% survival. Now, again, unfortunately, 1% of our patients with this condition. This morning, we heard the AML group, I don't know who was talking about this, I think Daber was talking about this issue of P53 mutated disease. And one thing that is very important that they were emphasizing in the morning is this issue of total therapy for this group of patients, in this case with very poor prognosis. So if you look at the graph on the right in the green, those are the patients that had some improvement in survival, that are those with P53 mutated disease that received total therapy, meaning some type of therapy, went to transplant at the time of best response, and then were maintained with therapy post-transplantation. Now, we talked a little bit about these oral HMAs. Let's talk about what's happening with these doublets. So if I had given this talk 3 or 4 years ago, I would have said 1, 2, 3, 4, 5. We're going to have 7 approvals next year. now we know that two of these studies, quote unquote, failed, the Panther trial and then this APR trial. Now, I'm going to talk for a minute about the Panther trial because I think for the community this is very important. Okay, so this was big study. MD Anderson was not part of this because, to be honest, we never saw actually that pevonidostat really added to the HMA. This time we were kind of lucky. But the reality is that this is a very well designed, very well powered. I think there were a lot of Italian patients also randomizing azacitidine, the standard of care, with this NET inhibitor or not. And phase 1, phase 2 trials showed positive results, and then we get this news that the phase 3 trial is negative. And what is very incredible, actually, from this analysis is if you look on the, let me see if I can do the, can you see that? No. Anyways, so if you look on the left, the CR rate with single-agent azacitidine in this study, 31%. So now the community really knows how to use these hypomethylating agents. You know, the best we had was 17%. We thought it was around 8 to 9%. And now in big randomized phase 3 trials, we are basically doubling the rate of complete responses in our patients. So we are learning how to use these compounds 15, 20 years later. And what happens is, you know, you have no effect on survival. Now the big question, and why I put this here, is how do we design the next generation of phase 2 or phase 3 trials now power for this kind of response? So just keep these numbers in your head for a second. So let's go quickly through some of the doublets that we have. Of course, the number one is not in particular order. The number one I'm going to show is that of the combination of an HMA with the BCL2 inhibitor venetoclax. I'm going to show you a couple of examples. This has not been published, has been shown many times at ASH and IHA. And we were very excited because you see here an overall response rate that is, 80-something%. But if you pay attention, the CR rate is 35%. So the question is this going to be actually better than single-agent HMA? We don't really know. That's why these randomized studies are so important. Now, I believe, and I just wrote an editorial about this, that what we need to really focus is on the survival of this type of doublets, not so much whether you get whatever response rate. So at the end of the day, I think we need to approve this based on survival data. And the study that I think is going to be fundamental in our field is the so-called Verona trial. This is the phase 3 trial of azacitidine with or without venetoclax. This just reached accrual a few months ago. It's going to take a couple of years to read because this is a survival trial. This could be our BIALE study. Now, is this data that I showed you preliminary with the venetoclax kind of really reproducible? I think so. This is paper we just published in Lancet Hematology a few weeks ago at MD Anderson in a more complex group of patients where you see this combination gives you an overall response rate that is between 80 to 100%, depending on how you look at it. And if you focus on the blue line, the median survival has not been reached. So this is basically in part to the phase 1 multi-center trial. So I think that this data is going to be positive, and it makes me believe that hopefully the Verona trial actually will be positive. Now, one thing that we are very excited, and I started with the oral decitabine, is the development of what we call total oral combinations. So this paper is being reviewed here, and what we did here was to combine the oral decitabine with venetoclax. So this is a total oral approach. And very preliminary analysis presented at ASH last year showed that actually this is quite effective with an overall response rate close to 100%, CR rate of around 33%. Of course, it's not going to be 100%, but if we stay around 80% with an oral compound with good survival and good tolerability, I think this is going to be really important for our patients. Now, Dr. Kola was very modest, and in her presentation didn't talk about really fundamental a paper that she published a few months ago in Nature Medicine, where she basically describes the type of stem cell hierarchy in myelodysplastic syndrome, and actually takes this forward to a situation where perhaps in the future we could predict who may respond or not to venetoclax-based therapy in myelodysplastic syndrome. So we're trying actually to do this in a prospective analysis, looking at different clinical trials where we use venetoclax in the frontline context. And this was done also by Dr. Irene Gagnan Gomez, who was a postdoc in her lab. Now, there are other approaches to these doublets in high-risk disease. One is sabatolimab, the STIM3 inhibitor. I think there's going to be quite a bit of data presented at the ASH meeting, so I'm not going to spend a lot of time here. You already heard this morning by Dr. Daber the interest of these CD47 antibodies for patients with high-risk MDS, this idea that perhaps this works for patients with P53 mutated disease. Now, when they first presented this data, they were talking about responses that were almost universal. But in the last update at IHA in Vienna, we saw actually that now the response rate is around 74%, and the CR rate is around 32%. Indeed, actually, the CR rate at least not very dissimilar from what we saw in the control with Panther. So we really need to wait for the results of these trials. Right now, the survival looks better than expected, but the reality is that we are all expecting also the results of this trial, known as the ENHANCE trial, that also reached its accrual a few weeks ago. So we're going to have two very important studies, Verona and ENHANCE, reading in the next couple of years for our patients in the frontline context. And then the French actually are starting to shift to something that maybe Dr. Kantarian has been advocating now for a couple of years, that is to think about chemotherapy like AML chemotherapy in these patients with high-risk disease. And this is just to show an example with the CPX351. I very rarely use this compound, but at ASH last year, they actually showed very high rate of response using ELN criteria, and actually a wonderful tool as a bridge of transplantation in these younger patients with this disease. Now, let's spend a couple of minutes on HMA failure. This still is a major problem here and at MD Anderson, probably the same in Madrid, looking at Adolfo. The only true phase 3 prospective study that has been performed in this disease is the so-called on-time trial with a drug called rigosertib. And the reason I'm showing this data here is not that this has any value in terms of helping our patients, but because it defines actually the natural history of this HMA failure. And what you see is that the survival is around 4 to 6 months. We're actually not doing better today than when we published this data around 6 years ago. There is some data perhaps incorporating venetoclax as an add-on to the HMA. I personally think that these results are kind of almost trivial. It gives you a little bit of a response. Perhaps those patients that are benefiting from this therapy are those that we miss that had an IDH1 or an IDH2 mutation. I think this needs to be really understood a little bit better. There are some studies, this is by Dr. Montalban in our center, using attenuated doses of CPX. This only has a value actually taking the patient to transplantation a few months later. I think, again, where the, as we say in the US, the money is again looking at this mutation. So this is not very frequent, but it could really help you. So around 10% of these patients have an IDH2 mutation, and they are very sensitive, both at frontline and relapse, to either venetoclax or to the IDH inhibitor, the same thing for IDH1. I'm going to talk a second about FLT3. This is something that you may not think about, but there is around 15 to 20% of these patients that when they fail or when they progress after an HMA, they actually acquire a mutation on FLT3. Very important. And then at the bottom, there are now kind of like a revival of drugs that target splicing mutations like this H3 bio compound. This is mainly for lower risk disease. But there is actually emphasis on compounds that target something called IRAK4, that is an important molecule on innate immunity signaling that is also controlled by splicing. So this is data by Dr. Takahashi a number of years ago showing the accumulation of these FLT3 mutations in patients with relapsed refractory myelodysplastic syndrome. And with that, actually, we designed this phase 1/2 study of AC220 quizartinib in combination with an HMA for patients with FLT3 mutated disease. There is some activity, and actually this can allow you to take the patient to transplant in some situations. This is the data with enacidinib, the IDH2 inhibitor, and I'm going to skip this because we see that these are nice responses. But what I find incredible here, if you pay attention to the survival graph, this is with monotherapy with enacidinib in HMA failure disease, and we just published this in Blood Advances a couple of months ago, that the survival actually is 22 months. So we don't have any data like this in this context of HMA failure with monotherapy. So this gives you the importance of doing this molecular analysis, and if you had the agent to target this mutation, how significant this could be for your patient. 2 words on transplantation. This is actually starting to change. This is a couple of years ago from the IBMTR. This is actually significantly better than the same paper 10 years earlier. At MD Anderson now we're starting to transplant people in the mid-70s, actually occasionally a little bit below 80 years of age. So we have clinical trials with more effective therapy. We're able to transplant more. And I think what's going to happen now is that we really need to think about incorporating these post-transplant type of approaches that we kind of pioneered around 10 years ago that are so important for patients with molecular features that will allow you to predict high rate of relapse, such as P53 mutations. 2 vignettes on 2 new compounds that are very excited, and this is actually also thanks to the work of Dr. Kola. So she identified as part of this analysis MCL1 as a major vulnerability in myelodysplastic syndrome. So we're starting this trial of AMG 176 with an HMA, maybe in combination with venetoclax for our patients. They just opened actually a couple of weeks ago. So thank you, Simona, for that. And actually through a program at MD Anderson that we call the Moonshot program, we have our own in-house CAR T cells, in this case actually this NK cells targeting CD70 that are going to open also a couple of weeks from now. So these are all internal drug developments that we've been able to to develop in our center. So to finish one slide, perhaps this is kind of a very rough. I would love to have a Mateo slide and then put my recommendation there. But I think it's very important to differentiate frontline from relapse disease. I explained that at the very beginning. And then you could see there perhaps how an algorithm in terms of how to approach these patients with AML-like therapy or not versus HMA, whether a potential role for transplantation could depend on cytogenetics and the molecular profile of their bone marrows. And with that, I want to thank you for this opportunity.